Hey guys, really early in the morning. Let's see if we can't get fetal monitoring knocked out of the system here. Let's get in here to where we need to be. Move my picture over if I could. It's even too early in the morning for the computer. Alright. You can finally see I need to clean some of this stuff off of my computer. Alright, there's your fetal heart monitor exam. Here we go. Fetal assessment during labor. I'm going to take myself off of here. I could put me way up here in the corner and make it smaller so you can see my beautiful smiling face, but you probably don't want to watch me all day. Alright. Put that down here out of the way. And slideshow. Computer's as slow as I am today. Alright, so today we're going to talk about fetal assessment. This covers chapter 18 in your book. And the reason we're covering fetal monitoring and antepartum, for one thing, it is where we will actually start using fetal monitoring is in the antenatal portion, even though we use it quite a bit more when we are in the intrapartum. We do have to do some fetal assessment during the time during pregnancy. So this is why we have put this chapter in this week. And this is a chapter that you will be referring to quite a bit throughout the weeks, throughout the semester, throughout the program, because this is the most important portion of intrapartum nursing, is that you know how to look at a fetal strip and be able to read it, much like reading an adult EKG. Your questions on the NCLEX, there's several questions on the NCLEX about fetal monitoring. So without further ado, let's see what it's all about. So what is fetal assessment all about? Well, it's an auscultation of the fetal heart rate. Years ago, more than 300 years ago, when none of us were alive, maybe our ancestors were hanging out, we actually developed methods of being able to listen to the fetal heart rate through devices. That some are still in fact in use today, such as the fetoscope, where you actually put a portion of it on your forehead and then put the stethoscope portion on the belly to listen to the fetal heart rate. And basically they do that because the sound of the heart rate will reverberate from the bone in the forehead much better, and you'll be able to hear it better. But we're basically the electronic fetal monitoring came about being around 1970, and it didn't do everything they thought it would do. They were wanting to prevent cerebral palsy, and they thought they would be able to detect cerebral palsy. Cerebral palsy is usually not caused by birth asphyxia. It's usually caused by some event that occurs in utero, such as if the baby's born term or if there's been some type of incident that occurs that causes harm to the infant. That's when we're going to see a lot of cerebral palsy. So the whole thing for fetal assessment was to prevent it, and it never did that. It was thrown into use without much research, so it's really not an evidence-based practice thing that we're doing. What it actually does is that it makes the nurse's jobs easier as far as being able to being able to see that fetal heart rate anytime that they look at the strip or look at the monitor that's out at their desk. It does help us, instead of just hearing the heart rate to see if it's high or if it's low or if it's changing, some of the things that we may not see if we were just auscultating ever so often. The electronic fetal monitor does help us visualize those fetal patterns. And since we've been using it, we have managed to determine what fetal patterns are and what they mean and what causes them. So it continues to be our primary mode of intrapartum. So, labor is a period of physiological stress for the fetus. So monitoring babies, monitoring our fetus is part of the nursing care that we do when we're doing labor. And one of the things that we're really watching for is to make sure that our fetus is actually highly oxygenated during labor so that we don't see a compromised fetus when we come out. So let's go to the next one. So these are some of the reasons why we monitor the fetal heart rate. Again, because we want to see what the fetal heart rate's response is during labor. Are we using too much of the baby's oxygen or the fetus's neonate? He's a fetus till his feet clear the floor, perineum floor, that is. So it's uh, making sure that we see how the fetus is responding to labor is a big thing, especially if we are having complications. We want to make sure that our fetus is responding well and still has oxygenation. So these are some of the things that we look for. Um, Fetal oxygenation can be compromised by a number of different ways, and I've listed them here for you. Reduction of blood through the maternal vessels, reduction of oxygen in maternal blood, alterations in fetal circulation, and the reduction of blood flow to the intervillous spaces in the placenta. And we'll talk about those as we go along. Restriction of blood flow through maternal vessels would be if you had someone who had preeclampsia or hypertension or um, possibly overdue, where the placenta is aging, so you wouldn't have the blood flow going through those maternal vessels. A reduction of oxygen content in maternal blood. Mom's not getting enough oxygen, then baby's certainly not getting enough oxygen. Alterations in fetal circulation would be things such as compression of the umbilical cord, um, placenta not working correctly, and then of course those intervillous spaces. This would be more of your preeclampsia and PIH than what number one would be. Reduction of blood flow through maternal vessels might be where she's dehydrated more so than what it would be the blood flow to the intervillous spaces. So let's look at some of those things that may cause what we're looking for to make sure that we're monitoring throughout. Now your book goes ahead and starts talking about fetal compromise, but we're going to just kind of hit the uterine contractions, make sure that you know that we're monitoring these as well. We're not just monitoring the fetus, but we're monitoring the uterine contractions. And the main reason we're monitoring the uterine contractions is because the uterine contractions can cause a lot of stress on the fetus, and we got to see how well our fetus can tolerate labor. So you need to know the frequency, how it's measured. It's measured in minutes from the beginning of one contraction to the beginning of the next contraction. That is different than the duration. Duration is measured in seconds from the beginning of a contraction to the end of the same contraction. So be sure that you note this when you're taking your fetal monitoring test, that frequency and duration have to be recorded in different methods. So frequency And I hope I pushed the button to record. That would be just awful. I'm going to have to go back and say I can't stand it. Oh, this is the worst thing in the world, trying to figure this computer out. Let's end the show. Yes, I did push the button. Thank God. I'm terrible at that. You guys, you just have no idea how awful it is. Alright. Good thing we didn't get too far into that. But I would like to rather check it now than check it later. Okay, so frequency again is that you measure it in minutes from the beginning of one contraction to the beginning of the next contraction. You see I have parentheses here that if you have more than 5 contractions in a 10-minute window, that's considered tactosystole. And if it's tactosystole, we have to intervene. So if we have more than 5 contractions in a 10-minute window, that's 2 contractions every, that's a contraction every 2 minutes. Get my math straightened out here. So, a lot of times you'll see the physicians think that this is an okay pattern, but when you start having a pattern like that, especially if you are have your patient on Pitocin, you will have to decrease your Pitocin because this is considered tactosystole. The baby's not getting, or the fetus is not getting any oxygenation enough between those contractions because they're occurring too close together. So again, our duration should not exceed 90 seconds. That's a minute and a half, but I don't want to really say it that way. If you think about it, if a contractions last to 90 seconds, that's 90 seconds that the baby is getting a decreased oxygen supply, and at some point not getting any oxygen because as the uterus contracts, the placenta is unable to uh, operate and send out oxygen through the umbilical cord. So there's a period of time that the baby doesn't get any oxygenation whatsoever. Then, of course, intensity. Intensity is how strong is my contraction? How strong is that contraction? This is one thing that you can't say, tell me on a scale of 1 to 10 how strong you think your contractions are. Because some women will think their contractions are out of this world when it's really not. Now, when we're talking about the strength of the contractions, we're not talking about how painful the contraction is, and the patient is talking about how painful the contraction is. What we want to know is how strong is that contraction moving in the uterus? Is our uterus having a contraction strong enough to actually move this baby in labor or not? So we can either use an internal catheter, uterine catheter, which requires ruptured membranes and dilation to use, and measure it in millimeters of mercury, and the normal is 50 to 80. However, the majority of us will be using palpation as to see how strong the contraction is. And rule of thumb is that, especially if you've never done it before, you want to lay your hand very lightly on top of it, or your fingertips on top of the fundal height, and see how strong the contraction is. And you have to leave your hand there long enough for the contraction to occur and then to be able to feel it during the duration. So how strong is it by feeling palpation? Well, if you will put your finger on your forehead, that is a strong contraction. So you feel how firm that feels under your hand? That's how firm that uterus will feel when during the contraction. If it's moderate, it's going to feel much like your nose. It's not going to be as hard as the forehead, but it's going to be harder than what you would feel if you had your fingers on your chin. Your chin is, unless you have a very prominent chin that has no skin on it, your skin, you should have soft with your chin. Now, in between contractions, we've got to make sure that we have a resting tone. And a resting tone is considered, if you're doing palpation, has the uterus totally relaxed? Does it feel soft like your chin? So is it a soft resting tone? or mild contraction. A mild contraction equals, you want it to be a little bit softer than that mild contraction was. It needs to totally relax. Without this relaxation, the baby's not getting any oxygen. And this is very important that we have resting tone and that we always document resting tone, especially when we are doing Pitocin, oxytocin induction, or any type of induction. So the external, when we're laying our hands on it, we should be able to palpate soft. That's the language we're supposed to use. If we're doing an IUPC, intrauterine pressure catheter monitor, then we would be going by millimeters of mercury again, and we should not have, we'd like to see it between 10 and 15, no more than 20. So once it starts getting up over 20, we start really getting concerned. And our intrauterine pressure catheter monitor was made for us to be able, or was invented for us to be able to do accurate measurements and be able to say this is 75 millimeters of mercury instead of saying it palpates moderate. So got ahead of myself, didn't I? Montevideo units range from 100 to 250 millimeters of mercury in that first stage, and it can rise up to 400 in the second stage. Now, you don't know all about the stages. Well, you may know about stages because I know a lot of you have gone through in your LPN program. You were introduced to Montevideo, or introduced to labor and how to measure contractions. So hopefully you'll bring that with you. So if not, we are going to review that when we do intrapartum on first stage, second stage, and all that. We will be reviewing that when we go into intrapartum. Contraction intensity of 40 millimeters of mercury or more, and or Montevideo units of 80 to 120 are considered to be adequate for delivery. If you are using an IUPC, which measures, that's the internal, and if it's measuring your millimeters of mercury, you should be able to calculate the Montevideo units and therefore keep your uterus from becoming too hypertonic. So the Montevideo units can only be calculated with the internal monitor. Remember that. You cannot do Montevideo units any other way. In order to figure up a Montevideo unit, you go to the peak of your contraction, say that your contraction peaks out at 80, minus your resting tone, which let's say your resting tone was 10, so that will equal 70, and you're going to do this in a 10-minute window. And for the sake of simplicity, we'll say that there were 3 contractions in that 10-minute window that were all equal. So we can say 3 times 70 is 210. So our Montevideo units would be 210. Now, most contractions are not going to be equal. Not all contractions are created equal. So you may see some that peak at 80. You may see some that peak at 40. So therefore, you would have to do each individual contraction by itself and add them together instead of saying, oh, there's 3 here that reach 70 and therefore we can do that. So be sure that you know how to figure your Montevideo units. So let me kind of give you an example of this is where your peak contraction would be. This is 60 millimeters of mercury. So that would be my peak. And down here's my resting tone. You can see here's 10. So it's resting tone at 10. Resting tone at 10. So I would say 60 minus 10 equals 50, and I would figure this up for 10 minutes. And that would be how you would figure up your Montevideo units. Now, I didn't put this contraction here to show you how to do the Montevideo units. What I wanted to show you is how the fetus is affected during a contraction. So contraction, so you start out with normal blood flow to the placenta without any contractions, right? we're happy, we're going along there, we're doing just exactly what we need to do. And then as the contraction starts, over here, your beginning of your contraction, you're going to see that the stronger the contraction gets, the less flow that gets. Then when it gets about halfway to the peak, there is absolutely no blood flow that goes into the uterus. So placenta is saying, I'm not, or the uterus is not getting any blood flow whatsoever. So right in here, your fetus is suffering from not getting enough oxygen. And then, of course, as the contraction starts to relax and starts to go down, you start seeing the blood flow starting to return and then back to normal flow. So this is why we want to monitor our contractions and periodic changes in our fetal heart rate. Now, in order to tell how often these contractions are occurring, or the frequency, remember I told you go from the beginning of the contraction, so the beginning of this contraction is right about here, and you don't go to right here. What you're going to do is you're going to go all the way over to the next contraction in the beginning of that contraction, and then you are going to measure how many minutes that's that contraction occurring. So you can't tell minutes here because we don't have it lined up for you, but that's how you would measure it, is from the beginning of the contraction, and then you go all the way over to the next contraction, and then we'll talk a little bit more about how to measure it on the fetal strip. Of course, if you were doing it by palpation, you would lay your hand on there till that contraction finished, and from the beginning of it, and then have to measure at least 2 to 3 contractions. So you might have your hands on her tummy for 5 to 6 minutes, depending on how often she's having the contractions. And this is where you have your being able to feel the intensity of the contraction. And then there again, when we're doing duration of this contraction, we're going from the beginning of the contraction to the end of the contraction. And duration simply means how long does that contraction last? Does it last 20 seconds? Does it last 30 seconds? Is it lasting at least 60 seconds? And we really like to see them lasting at least 60 seconds, but we don't like for them to be more than 90 seconds, because then and there again you're going to have too much time there that you don't have blood flow. So this isn't a very good picture of fetal monitor strip. The ones that you have on your test are much better than this one. This is just kind of where I wanted to show you basically about the contractions. So each one of these blocks, these big blocks, this is a minute. And within the minute, there are 10, there are, I think it's 1, 2, 3, there are 6 columns that count 10 seconds for each column. So this contraction beginning here, and it doesn't end until about right here. So there's 1 minute, there's 2 minutes, and just a little bit over. So you could probably say this, that she's having contractions approximately every 2 minutes. Now if this or 2.5 minutes, because you can actually bring it on over here, you would have 20 seconds here, so that would be about 2.5 minutes. Then we go from this beginning over to this beginning and add those up and know how many minutes they are. The duration, of course, are going to be these little 10-second blocks, which are hard to see in this scenario, but you'll have one that looks better than that. So each one, 10, 20, 30, 40, 50, 60 seconds duration on that one. This one over here is a little wimpy contraction, isn't it? It's like 10, 20, 30, 40 seconds on this one. And the peak of it, if we have an IUPC in, the peak of this one looks like it's probably around, let me get a hold of my mouse. Where'd you go, Mr. Mouse? I think they just disappear and appear whenever they want to. So the peak of this one compared to the peak of this one, you can see they all have a little bit different peak. So if you were figuring up your Montevideo units, you would have to do each one of these separately. So this peak looks like it might be around 40. Resting tone, it looks like your resting tone is around 20, and this is not good. Or those may be 5. I'm not for sure how they have the monitor. When you're actually going to have to read this, you have numbers alongside here that actually tell you whether these are 5 or 10-second ones. So um, depending on, if this was 40 and this was 20, that would be a 20 plus this was up here at 80 minus 20, which would be 60. 60 plus your 30 is 90, and so forth until you reach that 10-minute window to get your Montevideo units. Basically, if you will just remember that you can only figure Montevideo units with an internal catheter, you will be able to get the question on the test. And we hadn't talked about fetal heart rate, so I really don't want to mention it here, but since I'm showing it to you, I will explain what it is. It's tachycardia. Anytime you have a fetal heart rate that is above 160 beats per minute, it's considered tachycardia. So 180 beats per minute makes this tachycardia. All right, so we're going to talk some about the fetal compromise. I just wanted you to explain how to do the uterine contractions. So you should be able to know frequency, duration, intensity, be able to do it by either palpation or by intrauterine catheter monitor. So you've got an external, internal methods. We also have an external, internal method on measuring fetal heart rate. We have fetal scalp electrode, and then we have the external monitor itself. So we'll go through that as soon as we get to it in the chapter. Fetal compromise is a bad thing. We don't like to see fetal compromise, and we actually can do some things that's known as extrauterine or intrauterine resuscitation. So the big thing about failure to rescue, you have to be able to, when you work in labor and delivery, you have to be able to know how to read your fetal monitor strips and be able to react to them accordingly. So the goals of our intrapartum means during labor. So the goal of that monitoring a patient in when they're in labor is to identify the normal from the abnormal patterns. I'm not sure I even want to teach you the terminology reassuring, non-reassuring, because we have supposedly are to have stopped using these two terms several years ago when um, there was a nationwide definition as to what terminology should be used in fetal monitoring, so that someone reading it in Canada would be reading it the same way as somebody in England and somebody in Podunk, Arkansas. So we should say normal or abnormal. Now you may see me or hear me say reassuring pattern every once in a while because I grew up with you either had a pattern that made you feel reassured or you didn't. But basically, it's a normal or it's abnormal. Normal patterns assure us of fetal well-being. It tells us that our fetus is well oxygenated. Our fetus has a normal oxygen base in there. We have good acid-base balance. So normal patterns tell us that our fetus is doing really well. Our abnormal patterns, of course, something's wrong. It's abnormal. So usually it's indicative of some type of fetal distress, such as hypoxemia, where we have a deficiency of oxygen in the arterial blood to the fetus. This hypoxemia can deteriorate to fetal hypoxia, which is inadequate supply of oxygen to the cellular level, if we don't correct it in utero. And if we can't correct it in utero, then our situation when the baby comes out means the baby's going to be suffering secondary hypoxia and be very difficult to resuscitate. So if we can resuscitate in utero, we would be awesome and pat ourselves on the back for being able to do such a good job. So this is an example of fetal distress. We're just chunking along here, doing just nice and pretty. Over here, we're going to talk more about variability and accelerations, but right here, this part of the strip makes me a happy little camper. It's all normal. It has your moderate variability. It has your accelerations that show that the baby is reacting to movement and CNS systems intact. So it's got all these good things. So if you were just watching your strip and it was looking like this, you'd be saying, oh, this is a category 1 strip. It's normal. It makes us happy. Then all of a sudden, something occurs. Me and my little arrow. Something occurs that we start having our fetal heart rate starts declining. And it declines and it declines and it declines. And it's very slow to come back up. If we will look down here, we have a contraction starting right here. Now, if you've got an external monitor on, you can't tell how strong this contraction is unless you have your hand on it. So just because it looks wimpy, because it only goes up to 25, does not mean this is not a really strong contraction. Because evidently, this contraction caused this fetal heart rate to react in a uh, pretty awesome deteriorating way, right? So it started right here. The contraction started here. When it started getting stronger in strength, look what happened to our baby. And it got stronger and stronger, and here we don't have oxygen, right? Oxygen to the baby's not going on, and it really drops down. This, what you're looking at right here, is known as a prolonged deceleration. It has occurred during a contraction, but it's prolonged and it doesn't meet the criteria of a late deceleration. It meets the criteria of a prolonged deceleration. So there's anything that lasts more than 2 minutes is a prolonged deceleration. So here you've got 1, you got 2, you got 3, you got 4 minutes. So you got a 4-minute deceleration, which is really kind of sad. And the nadar down here looks like it's hitting around 90. Now this could be caused from this contraction. This contraction could have been. This contraction looks to me like somebody gave her too much Pitocin and caused us to have a really strong long contraction. Although this can occur without Pitocin being uh, administered, not administrated. Told you I was half asleep. Okay, so this is just giving you an example of fetal distress and what can happen. And this happened inside utero. And we have ways that we can actually um, resuscitate. And we'll talk about those after we learn a little bit more about monitoring techniques. There's different ways that we can monitor. We can do intermittent auscultation, which means that we can either take our fetoscope or depending on the gestational age of our patient, we can use a stethoscope. If you've got someone who's really heavy, who's obese, it's very difficult to hear fetal heart rates doing auscultation. But it's also difficult to maintain fetal heart rate on an obese patient with an electronic fetal monitor. So there's a challenge either way. The intermittent one's easy to use. It's inexpensive. It's less invasive. However, it's also more manpower is required. Auscultation is done intermittently, which means you do it however often for whatever stage labor the patient's in. For someone who is going through a normal labor and delivery and not anybody that's at risk, usually every 30 minutes to an hour is recommended by A1. And then when they get to that second stage, anywhere from 5 to 15 minutes has been recommended. So depending on your hospital policy as to how often you should be doing these fetal heart rates. Now that doesn't sound really too bad every 15 minutes or every 30 minutes to an hour. But by the time that you Listen to the heart rate before a contraction, listen to the heart rate during the contraction, and then listen to the heart rate for a period of time after the contraction. You've spent at least 5 to 10 minutes in there doing your one heart rate intermittent auscultation. So that's why nurses tend to like the electronic fetal monitoring better, because all they have to do is just glance at the monitor. Now, the intermittent auscultation also gives you, since it does hands-on, it gives you more. You have to have a one-to-one nursing ratio with the patient. It also establishes a good nursing relationship with your patient, so that you're really more helpful to your patient doing a one-on-one with the auscultation. Whereas the electronic fetal monitoring, the nurse can sit at the desk and monitor the patient for several hours before she goes back into the room, if she chooses to do so. It also lets you do 2 to 3 labors at one time until they get to the point where it's 1-to-1. So what about this electronic fetal monitoring? You've heard me say external, internal, intrauterine pressure catheter. So let's talk about these for a little bit. Your external monitoring is where the device is. You can either do external with the electronic. If you look in your book on page 414, there is the basic fetal monitoring setup is the one that's down there at the bottom of page 414, where the patient's strapped. She's got pink strap on the bottom, blue strap at the top. One of them's reading the fetal heart rate, and one of them's reading the contractions. So basically, the transducer, the ultrasound transducer, is the one that's on the bottom and reading the fetal heart rate. Now they know that the fetal heart rate's there because they did Leopold maneuvers and figured out the back of the baby, or the baby's back, is in that direction. So that's where they put their monitor. Then the TOCO transducer measures your uterine contractions. It's placed over the fundus, and it will actually is a pressure sensitive device that can measure and record the frequency and the duration, but of course, again, it cannot measure the strength. I really like that wireless and beltless system that you see given. They give you an example of that. This is only used in very high uh, in hospitals that can actually afford to do this particular type of machinery. I think it would be very awesome, because then the patient can get up and ambulate and move around and do whatever they need to do instead of tying them to the bed. Although you can get them up out of bed and get them on a ball, get them in a rocking chair, let them do some swaying, as long as they're still connected to the monitor and the monitor is still uh, picking up contractions. And like I said, it's really difficult sometimes um, for an external monitor to be to stay. If you've got a very active baby, if you've got someone that's obese, this is where you might be looking at an internal for fetal monitoring. Um, so we talked about the transducer and the TOCO transducer. The transducer does the fetal heart rate, and the TOCO transducer measures the pressure of the fundus. Then we have the internal monitoring, and this is either a spiral electrode or the intrauterine pressure catheter. So, again, if you'll look on page 416 in your book, it shows you an example of the intrauterine pressure catheter, and it can be fluid filled, or um, it can be solid. And those are things I don't really expect you to know, but the ones that are fluid filled, you can actually do an amnio infusion with those. And that's very important when you're having someone who's having having a lot of variable decelerations. You can actually put more fluid into the uterus and raise the baby's body part up off of the cord, because variable decelerations are caused by cord compression. The fetal scalp electrode. Now the spiral electrode is inserted on the baby's scalp, it doesn't go in very far at all. I mean, it's just a teeny tiny uh, spiral that connects with the scalp. It doesn't go through the bones. Doesn't go through the skull, but it just actually connects to the scalp, and it will actually be an EKG of the baby's heart rate. So you are actually getting, instead of getting an ultrasound of it, you were getting the actual heart rate. Years ago, it used to make a whole lot of difference because our monitors weren't as good as they used to be as they are now. So used to, if you had a bad strip, couldn't keep the baby on there, and you put on a spiral electrode, and it showed you the exact thing if you can't, so you can see exactly how the baby is moving around and how the heart rate is doing. So um, this intrauterine pressure catheter is it's got a pressure sensitive tip, and we've talked about millimeters of mercury already, and we've talked about how it can objectively measure the frequency, duration, and intensity. Um, you should be able to use this to evaluate the adequacy of uterine contractions more so than if you were palpating them, as we talked about the monovinale units and how to use them. So be sure that your monovinale units do not exceed 250, although they can. You want to make sure your doctor realizes that they are exceeding that, because there's no point in using an IUPC if you're not going to use the results of the IUPC to manage your patient. And then, of course, you have your display of your fetal heart rate patterns. And we see a lot of the fetal heart patterns, and there's several different ones that we're going to talk about. Um, and again, we got we had a lot of crazy, it does this, and therefore it's not quite this, but it's partly this, and so forth and so on. So um, the meeting that occurred several years ago did away with all that, so it made it a lot simpler for you to take this exam. So yay. So in order to read fetal monitor strips, you've got to know the baseline. So the baseline fetal heart rate, you're going to have those intrinsic rhythms of the fetal heart rate, where the CNS, your central nervous system, and your autonomic nervous system are going to really are what controls your fetal heart rate. So in order to see how well the CNS system's working, how well the autonomic system's working, we actually study the variability and the accelerations, decelerations of the fetal heart rate. So basically, just like you and I, when the fetus uses oxygen, the heart rate should increase. When not using the oxygen, the heart rate will decrease and bump along there at their baseline. So, if we're chugging along at a 80 heart rate and we go out and we do some exercise and use up some oxygen, our heart rate will go up by, maybe to 100 or so. And the same thing with the baby. If the baby's chugging along at about 140 beats per minute on his little fetal monitor, and then he moves, he uses up oxygen, and his heart rate should increase. And it should increase by at least 15 beats per minute for us to be able to determine whether or not he's oxygenating well. So, continuous metabolic processes that are adequately met will produce a jagged heart rate strip. Basically, what that means is you will have moderate variability. Your strip will look just like you took your pencil and you made little jaggedy lines all over in a straight path, but little jaggedy lines all the way across. So, whereas we used to do the And when we still determine some of this by how many beats per minute, moderate variabilities is, and we'll talk about those in a little bit because I'm going to confuse you. You're going to be worrying yourself, what's that? What's she talking about? So let's just talk about what we want to know, that our baseline heart rate should be at least a 10-minute segment that excludes periodic and non-periodic changes, and of course exclude the periods of marked variability. So in order to know what the non-periodic changes and periodic changes are, it can't be a contraction, it can't be a variable deceleration occurring. Anything that is occurring other than the fetal heart rate is how we're going to determine that baseline. So you really want to have just the 10-minute segment that excludes any of those things. Periodic would be like a variable deceleration. Um, Episodic would be if it occurs with something else that occurs, like a contraction. So we have to discontinue. We can't use those as baselines. We have to have at least 2 minutes of interpretable baseline data in that 10-minute segment in order to determine that baseline. So we take a 10-minute window on our fetal monitor strip, and out of that 10-minute window, we've got to come up with at least 2 minutes where there isn't anything occurring, such as an acceleration or a deceleration. Um, so after that 10-minute, we round it to the closest 5 beats. And it has to be reported in increments of 5. This was another change that they made. We used to give ranges of, it was 140 to 145, but now if the heart rate is 143, you would report 145. If the heart rate was 141, you would report 140. Because everything is only as good as the time that you're seeing it. Things can change extremely quickly. So this is the baseline fetal heart rate. Now we're going to talk about variability. Variability is one of the things that tells us a whole lot about our oxygenation of our fetus. And moderate variability is probably the best indicator of acid-base balance in your fetus. If you don't have variability, you've probably got a bad baby if it's not related to either that you gave the mom drugs or you gave babies in a sleep pattern. So basically variability is irregular waves or fluctuations in the baseline, 2 cycles per minute or greater. It does not include accelerations or decelerations. And again, you don't know what those are because we haven't gone over them, but we will. It's quantified in beats per minute. And there are actually 4 categories. And the 4 categories are absent, minimum, moderate, and marked. And there are some things that are actually going to affect those. Now, one thing I want you to be sure to look at on figure 1817 on page 418, it's showing you the difference in the categories. But what I want you to be sure to do is to read what's down there, because it tells you that absence means that there is absolutely no amplitude whatsoever. Minimum amplitude range, B, which is minimum variability, it's going to be the amplitude is detectable in less than 5 beats per minute. And C is 6 to 25 beats per minute. And then D is greater than 25 beats per minute. This is going to be on your exam, so on your fetal monitor exam. So you want to be sure and make a note of that so that you can go back to this when you're taking your exam and be able to tell me what those amplitudes are. When you have absent and minimum, they are abnormal. You do not want absent or minimum variability. This will worry you more than late decelerations. It's just indicative of hypoxemia, could be metabolic acidosis, could be congenital anomalies, pre-existing neurological injury. Of course, if you're lucky, you may have this right after you administer Demerol or barbiturates, tranquilizers, even sometimes when you administer promethazine. So you want to be sure that you are aware that there are certain things that can cause absent or minimum variability. But if you have absent or minimum variability and you have not given any of these drugs, it could be mom took her own drugs at home we need to find out about, or it could be that there is been an injury to the infant in utero that um, has caused it to become hypoxic. Um, Sometimes, of course, we may see that babies in a sleep cycle, but usually when they're in a sleep cycle, they're more in a minimum than they are in an absent, and it usually never lasts longer than 30 seconds. So if we have minimum variability and tachycardia, that's a really bad thing for us to be having our babies in severe hypoxia. So we need to be sure that we're looking at that. Of course, your moderate variability is the kind that you like the best. It's considered normal. It's highly predictive of a normal fetal acid base, as we've been mentioning, and the absence of fetal metabolic acidemia. Um, I'm sorry, I'm so hoarse. Moderate variability indicates that your fetal heart rate regulation is not affected by fetal sleep cycles or anything as that. Marked variability, we really don't know what causes marked variability, and because we don't know what causes marked variability, we just don't like it because we don't know what it means. We are dumbfounded by it. Now, a sinusoidal pattern, which I haven't mentioned, a sinusoidal pattern is where you have a wave-like pattern. Um, it's not usually considered part of your variability, but it is a pattern that you need to be aware that you should be very uh, reactive to. You should call your doctor if you see a sinusoidal pattern, and there's an example of that in your book. There's an example of fetal tachycardia. But the sinusoidal pattern usually is associated with maybe infections such as chorioamnionitis, fetal sepsis, and sometimes with administration of drugs. Stadol especially can cause a sinusoidal pattern. But if you have a patient comes in that has a sinusoidal pattern, it's very much indicative of anemia, possible blood loss between the fetus and the mother. So you could have a partial abruption going on, you could have hydrops going on, but it's a big major marker that that your baby is becoming anemic for some reason, either through loss of blood or destroying of the fetal blood. Something's going on and that's not good. So here's your absent variability. I would probably say you would get by with calling this minimum variability, because do you see some movement here? There's some little jaggedy movement here, but then when it comes over here, it's very much like there's only two little things there. So this would be more toward absence. If you call that minimum, I would not say that was wrong. So, with minimum variability, we've already talked about it, but be sure that even though I've got this can last up to 40 minutes, because a lot of the classes that I've gone to say that it can last up to 40 minutes. I have changed this to last up to 30 minutes because your book says 30 minutes, and so it's been changed on your exam to say 30 minutes. So be sure that you realize that lasting up to 30 minutes is what we're looking at. If it's more than 30 minutes, we start getting concerned about it. Usually you will suspect a sleeping fetus if your strip has been running along just perfectly fine. It has good moderate variability, and then all of a sudden it has minimum variability and nobody did anything. Baby just got tired and decided to go to sleep. The sinusoidal pattern that we talked about is very indicative of the hemolytic disease of the fetus and can also be minimum variability as well. And minimum variability looks like this. So minimum variability is the undetected less than or equal to 5 beats per minute, whereas your absence was 0 variability. So you can see this strip looks a little bit more active than the absent did on that one end. Moderate variability, we like moderate variability. Remember this smug little smiley face. We're feeling pretty smug about that. It's a normal pattern, highly predictive of normal fetal acid base, and it really throws us for a loop when we have this baby that's born that's having difficulty when we've had a nice, moderate, normal looking strip all along. And this is what it looks like. Although to me some of this looks a little bit more like a little bit marked here. This a lot of activity going on here. This of course has the amplitude of 6 to 25 beats per minute to define the moderate variability. I forgot to park my phone. So marked variability, again, we're not sure what we're going to do with that. We don't know what it means. And this is what it looks like. And it's greater than 25 beats per minute. Okay. Tachycardia. This is when your fetal heart rate is higher than your baseline of 160 beats per minute for at least 10 minutes or more. So if you got, say you had an acceleration that occurred for less than 10 minutes, that was 180 beats per minute, that's not tachycardia. But should that acceleration rise from 160 to 180 and stay there for over 10 minutes, you've had a change in baseline and it's become tachycardia baseline. It's an early sign of hypoxia sometimes when you're seeing a baby running tachy. They're not getting enough oxygen and their heart rate increases just like it would with anything else. It can be related to maternal temperature, so always check your mom's temperature whenever you start seeing tachycardia. It's also a high indication of fetal infection, especially if mom is running a temperature, but the fetus can actually have infection that mom's not. It can also be related to medications. So, let's see if I changed my things right. Nope. I thought because the chapter was falling in the same spot the pages would be, but evidently it's not. So, it's table 18.3 that we want to look at. And table 18.3 is, where are you, table 18.3? There's box, box. Table 18.4, so I've missed it somewhere. Well, that's because I was looking right at it. It is now on page 419, and it's table 18.3. So I thought I'd changed all these. Evidently, I forgot to change this one. So this really goes through and gives you definitions of tachycardia as well as bradycardia. what can cause them and the clinical significance of them. And because it has clinical significance here, and we've been talking about clinical reasoning, look at that and see if that would give you some kind of idea of what we're looking at for clinical significance, is what this might mean for us and what we need to be assessing for. And then, of course, our nursing interventions are going to depend on what the cause of this tachycardia or bradycardia, whichever one it is. If they have a fever, we're going to give them antipyretics as ordered by the doctor, because he's going to have to be notified we have tachycardia. Maybe some cooling measures. We might be having to give some oxygen, 10 liters per mask by non-rebreather face mask, and carry out all the specific orders that our doctor gives us. Tachycardia is something that's, if it's not related to a fever, is difficult to resolve until you actually have the delivery of the baby, because we have so much that it could be that we don't know what it is. Bradycardia, same thing. Now, see, I changed that one. No, I changed it to 18.3, but I forgot to change the page number to 419. So bradycardia is when it's less than 110 beats per minute that last 10 minutes or longer. True bradycardia rarely occurs, and it's got to be distinguished from a prolonged deceleration. Bradycardia relates to the heart anomalies of the fetus, maybe viral infection, maternal hypothermia or hypoglycemia, but usually it very seldom occurs. When it does occur, it's not a good sign either. So let's talk about periodic and episodic. Periodic changes are those that are related to the uterine contraction according to your book. And then episodic changes in the fetal heart rate are those that aren't associated with uterine contractions. And that usually that means that we're having accelerations and decelerations. So, we need to define what these accelerations and decelerations are so you'll know what I'm talking about. So an acceleration, you see I've got the little gas speedometer up there. It really speeds up. So a definition of the acceleration is defined as visually apparent abruption, means you see this. You see this. Increase in the fetal heart rate above the baseline, and then it means that the onset to the peak is less than 30 seconds. Means it's going to take it from as little as 30 seconds or less to get to that peak of that acceleration. The peak itself must be at least 15 beats above the baseline. So if your baseline was 160, the peak for you to have an acceleration would have to be at least 75. It's got to last for 15 seconds or more, and it's got to return to the baseline less than 2 minutes from the beginning of the acceleration. So it's got to last at least 15 seconds. It's got to be at least 15 beats above the baseline to be considered an acceleration. If it lasts for more than 2 seconds, it's considered a prolonged acceleration. If it lasts for more than 10 minutes, it's considered a change in the baseline to tachycardia. If you have preterms before 32 weeks gestation, acceleration is 10 beats above the baseline and lasts 10 seconds. If a 32-weeker or above, 31, 32, ever reaches the 15 by 15 definition, then they are considered, the 10 beats by 10 beats will not apply to them, because they have proven that they can actually meet the criteria of a term infant's accelerations. Accelerations, we love them. They indicate fetal well-being. They indicate we have an intact central nervous system. We are able to, the baby's able to move around. The central nervous system says, hey, we need more oxygen. Therefore, they increase the heart rate, and the heart rate increases, and that's why we see accelerations. A lot of times they occur with fetal movement, but they can also just occur spontaneously. You can use an acoustic stimulator to elicit fetal accelerations if you have a patient on monitor and you're not seeing any and you'd like to see them. An acoustic stimulator is that device that you'll see people using with a trach to be able to talk, and you can just buzz them with that. Usually you'll see them spread all four legs out, or all four extremities. I don't guess they have four legs. Let's hope not, unless you're doing your baby's dog. So this is what they look like. You notice down here there is absolutely nothing going on down here. So these accelerations are not going to be occurring, are not periodic changes, they're episodic changes. Usually if you are seeing fetal movement, there's a real sharp line that jumps up here and jumps up here, and that's usually fetal movement. So these little blibs right here could be fetal movement. This right here could be fetal movement. So if you look at your strip, your baseline is running what? We've got about a 140 right there. We go over here, it looks like you've got about another 2 minutes there. So we'd probably call that baseline 140. So if we call in our baseline 140, we've got 10, 20, 10, 20, 10, 20 that's lasting for how long? 10, 20, 30 seconds. So we've definitely got an acceleration that meets that criteria. And this heart rate is 160, so it's 160 based on 140, so it's 15 beats per minute above the baseline. So that's what your accelerations are going to look like. These little blibs here are not accelerations. They are not meeting that criteria of being 15 beats above the baseline. And I think I'm going to have to stop here because I have a meeting, so I'm going to stop here and we're going to pick this back up for part 2 of accelerations, if that's okay with you guys.